So I farm so hard the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
What's good, fam? It's your host, Jim Pruitt, aka Farms in the Easy, and I'm bringing you another episode of the Farm So Hard podcast. This one's going to be a really cool scenario where we're taking some of the work that we did at the SCMP, Residency, RPD, Roundtable. We're taking things that we've done inside the society and make sure we convert that to a medium that is the most conducive for you guys. So we want to make sure that you heard all the questions, saw the presentation, and really was able to be involved in that process if you missed it that day. So we're going to put that RPD Surveyor Roundtable together, and what you're going to hear is going to be clips from that. So I hope you guys enjoy this component. Big things to look out for is, of course, that we have the 5th annual Empower RX conference coming up April 10th and 11th in Orlando, Florida. And for you guys that don't know, again, we recently was able to start the Society of Emergency Medicine Pharmacists, and this is going to be a recording from one of the events that we've done there. Super excited right now. If you're hearing this, we're recording this component from mid-year as we really start to focus on this next year or so. Definitely reach out to us, let us know what we can do, and of course, for everything you do, guys, make sure you farm so hard.
You know, it's, I guess, try and minimize the paperwork if you can, I would say. But this is something I think really see from, sometimes it may be people don't understand, or there's just lots of paperwork to be completed. I think ASHP is trying to reduce some of this. But things with paperwork like policies, you know, that you have a policy for the standards, and that's definitely something I would recommend. It seems boring, and it can be boring, but if they're surveying you on the standards, make sure you understand what those are, and that's probably the best way to prepare. But if they require you to have a policy on if you have a policy on recruitment, or the standards say that you have to have the pharmacy resident has to be a licensed pharmacist for 2/3 of the residency, then you might have a policy around those type of things, or if there's hospital policies. But just make sure those things are consistent. And this paperwork becomes an issue when there's multiple programs, so you are not the only program. So there's a PGY1 program, there's critical care, there's emergency medicine, there's infectious disease. I think you can have some efficiency there if people's policies or whatever requirements you're going to have match between them, rather than everybody having a slightly different policy, or not updating those policies. That's another. You might have one like on the one that you revised for ASHP survey, and then the one that you give to the pharmacy resident, or the one that's on your local intranet site. If all those things don't match, that sometimes comes up as a finding, that all of those things really have to match, so that you're giving the consistent information to the residents, and if there was ever an issue. Also, I think with paperwork as well, with some of these things, like you have to have learning experiences for all your required or elective, is to try, if you can, and be as efficient about that as possible. So for example, if you have 10 different learning experiences or 20 different learning experiences, do you need all of those, or can some of them be combined into a larger learning experience? You know, is it a longitudinal emergency medicine practice versus individual months for that? And these are just different ideas or ways to do it. But the more learning experiences that you have, the more paperwork that you will have to make sure is updated and is accurate. Other things for paperwork is to make sure that you're keeping track of all the requirements that you say the resident has to complete to receive their certificate. So some of that is the standards. You know, they have to go over all of the required standards goals and objectives for the residency. They have to do all the required ones. But are there other things that you require them to do? Do you require them to attend a local meeting? If you want that as a requirement that the resident has to do that, then you should be tracking that to see if they're going to do it or not. If some of these, and sometimes people don't think of it that way, they're putting it on the list, but they're like, oh, well, they don't necessarily have to do that. So I would say, that list really should be things that if the resident doesn't complete this, they will not complete the program. They will not be able to get a certificate that you're tracking that. So that can be tracked, with your development plan, the quarterly development plan. So that I think that's a great place to put that. But again, just the things that are not everything, So again, if you have staffing and you have they have to complete this many shifts that you're including that. If they do some type of you allow moonlighting or elective shifts and that's not required, you don't have to look at that as a requirement. You might look at that for duty hours and making sure they're not going over for that. But again, only the things that are really required, don't have extra things in there that aren't important. Another thing that see frequently is for recruitment, especially if you have any type of scoring rubrics or way that you're evaluating the candidates, that you have some process for that. It doesn't necessarily have to be a policy, but how do you score all the candidates so that it's all the same between them? And if you have a score, to not allow things like half points or 1, 2, 3, 4, 5, if you could have something like 1, 3, or 5, so that it allows more of a difference between the candidates. So you don't wind up with similar scores between evaluators. And then another thing with paperwork is to have everything match. Again, if you have your website from the institution, or if you're a College of Pharmacy, from the College of Pharmacy, advertising your program, saying that these are the required learning experiences, these are the elective learning experiences, and then you have a residency manual that says these are the required and these are the elective. And then you have information that you give to the residents when they come to interview. You want all that information to match. Many times, if it's not a brand new program or you're working again with a bigger institution with multiple programs, sometimes these versions can get mixed together. So making sure all of those things match. Another is timeliness of evaluations. I think that's not just with emergency medicine, but with all programs is something that's challenging to stay on top of. So the way I think of it is like, if you're on time, that means have you completed your evaluations within 7 days of their due? So that's on time. You're late if it's done within 2 weeks, and then after that, as long as it's done by the end of the program. So there's no more scoring or gradation of is it late or not. So it's either, within 7 days, 14 days, or then, as long as it's done before the end of the program. So it's really compressed to try and get it within a short period of time. So one of the things I would recommend here is to try and limit the number of evaluations that you have that are completed on paper. We may do a lot of evaluations at the bedside in the moment, just face to face. Those aren't necessarily documented. I think those, especially for many of the emergency medicine mentality, that's the things that we value most. It's just that in the moment, you want to see it, want to see what you're doing, have the hands-on experience. But at least with Pharm Academic, with a learning experience or your quarterly evaluation, those have to be documented. Try to minimize those if you can. Have the smallest amount that is okay for your program, because again, the more of those that you have, the harder it's just going to be multiple things to keep on top of. Another way to help with this is if you have a learning experience in the emergency department, could be other learning experiences where you have multiple preceptors. Now there's this option for the team-based summative evaluation. So with this, multiple people, if three people, preceptor A, B, C, are assigned to that evaluation, they can all contribute simultaneously to the same evaluation, and the primary preceptor is the one who submits it. So you don't have to have three different evaluations for that. So that can be another way to try and minimize paperwork. And I think another thing that's good about that is it shows, rather than three different evaluations, it shows how everyone contributed to the residents' learning. So I think those are really the common things I can think off the top of my head.
Perfect. And that's a lot of the information that we're going to be kind of putting all together. But to me, as someone kind of going into this, the big things I'm taking away is if the standards and the KGOs don't require you to document it, less is a little bit better in that standpoint, and everything being in one spot that we can just point directly to. The thing that makes me the most nervous, I would say, is making sure that we have the have quality in the evaluation so that we don't have to keep sending it back and forward. And it makes me nervous figuring out when is time zero. So say for example, I'm on my EM1 rotation and my first preceptor does a great job of providing me the initial feedback on time. But when I look at it, they give a one sentence kind of comment on that particular thing and they didn't, and let's say they had needs improvement. They don't provide that amount of information. The next step, of course, for me is like, hey, we don't have enough information. We probably gonna have to send that back to that person. Where I get nervous in the time frame is, okay, you got it to me on time, but it wasn't appropriate, so I had to send it back to you. And now I believe that clock starts over. At least that's what I'm concerned about. Is that necessary? Are you aware of things like that happening where, say, for example, a person sends over their evaluation, then the RPD says this is not enough information, and I have to send that back to you because you didn't give me any examples. When I send that back and say that preceptor gets back to me on day 8, after that, is that considered a late evaluation at that point?
No, no, they've changed that so that within the Pharm Academics software, it's supposed to only count the date of the initial submission. So if you submitted within that 7 days and then you say this has to be sent back for revisions, that shouldn't count against the timeliness of the evaluation.
Perfect. Because one of the strategies that I can see some people, telling their preceptors, hey, get me something in. Get me something in beforehand. Ultimately, I won't accept particular feedback that's not, giving me exact examples and telling me what the resident can do to get better, because that's not great. Because sometimes we'll have a very good discussion, but the form academic doesn't match that discussion. So that's something that I try to talk to my precepts about. But would love to hear others' feedback on what they're doing when it comes to a lot of these documentations and policies. I have a few RPDs on right now, so I wanted to see if anyone else had any comments on how they're setting up, whether they're storing policies on Teams or OneDrive, or if are you putting it on Form Academic? What are you guys doing when it comes to like keeping all your policies and paperwork in one location? I would love to hear from other programs.
And I thought, well, people are thinking of that, Jimmy. I thought of another thing, and as far as a common finding, is kind of the quality of feedback, not whether it's on time or not, and even not necessarily how lengthy it is, but many times people will tell you, like, this is the standard that, resident, is able to, display the critical role or the essential role of the emergency pharmacist in a medical resuscitation. People will say, oh, they were great at this, they did this, talking about all the things they did, but really what's most important to see is not what they did, but what they didn't do or how they need to improve. So it's not so much about what they did do, because many times people will say that, they were able to give recommendations, they were able to, help administer medications and not, were not nervous or were able to think clearly in a stressful situation. which that's good, but really what's important is like for the development of the resident. So what are they not able to do? So they were able to do those things, but did they have difficulty with challenging providers still? They were able to make a recommendation or certain situations that they weren't comfortable with or something, and thus if they're not comfortable with or weren't able to give recommendations with difficult providers, then we would recommend, if you have a certain area, if it's surgeons as a stereotype, or a certain area or a different type of experience, you would recommend them to practice to get better at it. Those are the really, if you had to limit your documentation, I don't think I would talk about so much what they did, but what they didn't do or what they need to do to go higher on their achievement of the goal, especially to the level of achieved. So I think that's the most thing that sometimes people don't include either. Well, they think that's negative. I don't want to put that in because that's negative, or whatever the reason. That could be one reason why they don't do it, but that's really the most important thing we're looking for. So even if it was limited, you don't want to limit the feedback on that to anything that they'll say, a survey will say is actionable. Like you
John,
didn't.
may I
Yeah.
tag on to that for just a second? It's
Yeah.
only negative if you didn't tell them about it at the time that it happened. If you're surprising them at the end of an eval with comments like that, then you're not doing your job as a preceptor, because they should have heard it from your mouth. And so it becomes immediate feedback that improves their performance at the time, if it's something they really shouldn't do or should be more cognizant of. And then you don't get any of the complaints. People get upset when they don't hear about it at the moment, and then they harbor that. And if there's one group that you absolutely should always be giving a lot of verbal feedback to, it's the residents in the year the residents in the year before and the residents of the survey, because they go out of their way in their session with the residents only. And I mean that sincerely, to get them to, well, come on, tell me the truth. There had to be one small thing that you really were upset about. And they will turn that one complaint from one resident into, you have to change your whole program. And I'm not exaggerating. It happened to me a couple of times. Forgive me for jumping in on it.
Oh, no. No.
Yeah, and I would like to just ask a few people to, since we're on this topic of feedback, and I feel like we never have a forum for those who's recently graduated or those that are currently residents, how they like feedback. And sometimes there's a mismatch between, again, when the surveyors go and talk to the residents and you start asking about this, we don't necessarily get exactly what the preceptor mentioned. So any of the preceptors that are on currently now, that's like a recent grad, and I've modified the settings, so you should be able to just unmute yourself. But I would love to hear from anyone who's recently. So Liz, AK, any of you guys, Yasmin, any of you guys has recently kind of been through training, or even if it's PGY1, I would love to hear your thoughts on like the best feedback for you, because I don't think sometimes we study or we don't assess always, okay, what's been the best feedback I've gotten. So anyone who wants to kind of unmute themselves or write in the chat about the best feedback for them, or that any preceptors that they've heard. So I would love to hear you guys' thoughts. So we'll move on to this next question that we have here, if we don't have anyone who wanted to kind of chime in on that. And John, for this one here, it's a slightly different tone. This one's going to be on what pharmacy service findings specific to the EM do you see repeatedly? Because I think this is something that we don't think about as RPDs and preceptors. The approach you guys take when you're serving a program is going to be more of a holistic. And I think this is a part that kind of take people by surprise with some of the findings that that come behind it.
One of the things that see frequently, and it's not even just emergency medicine, but I would think it's even just many residency programs. And you talked about this, Jimmy, in the introduction, about the adequate administrative time for the residency program director. So they approximate that to 4 hours a week, or 8 hours a 2-week pay period, or 16 hours a month on average. is what is expected of the standards, and that's something relatively new within the most revision. And that's one of the things that I think is challenging for many institutions, academic, non-academic. Um, it can depend on just the amount of duties that you have to do every day as far as your daily clinical activities, administrative activities, teaching the residents. But that's one of the ones I think many of the institutions struggle with. Um, and with that, I think hopefully this is one of the things with ASHP, they will put this, and try and hopefully to the administration, pharmacy administration or hospital administration saying this is a standard, you know, this is important for them to have this act for development of the program, doing all the paperwork and things like that. But that's one of the things I think many are challenged from. I think it's difficult too with more specific to the emergency department that, we don't have as much of a schedule as like rounding services necessarily, like where you might say, oh, typically we round up until noon or 1 o'clock, and then the afternoon, you're following up and doing other. It's there's not necessarily a routine in the emergency department, which can make it difficult if someone might say your supervisor or someone else might say, well, it's typically not busy at this time during the day, so you should be able to do that work when it's not busy, but it doesn't. So I think that's something more unique to the ED, where it might, this week I had it, but last week I didn't have that. It's not consistent. So I think for ED people, it's really important if you can um, have that time away, or if there's cross cover, where there's somebody else covering your duties, where you can do something else and step away. Probably not just for the administrative time, but other things as well, topic discussions, all of that. It's a different environment that makes it difficult to do those administrative, academic type of activities. So that's one thing. It seems like it isn't, but it's tied into pharmacy services. Not so much like verifying orders and other type of things, but that's probably one of the most common things I see are on the list. Another and two, I guess, related are medication overrides as well
Mm.
as auto verification. So if you're not familiar with that, and that's okay. If you have someone in med safety or an IT department that works with that, that's something that ASHP will be talking about. Definitely overrides and medication safety with overrides has been something they've looked at for a long time, trying to minimize the amount of drugs on override. So that just minimizes the access, minimizes the likelihood for an error. I think it's more challenging in the emergency department, and especially challenging depending on how you have that set up for your dispensing cabinets. Do you have it set up as, just everything's on override and it's not linked in with your system, or is it profiled where it's linked in? Um, so as you're as a program director, or if you're even looking to start a program, that's something I think that'll be interested as a medication safety. And I would say try and, limit those if at all. So things like, you could have Tylenol. Why is Tylenol doesn't seem that emergent, or other drugs like oral antibiotics? Is it really emergent, or could you wait for someone to verify that? So look through that list and see if there's something that could be taken off if it really isn't an emergency type of medication. Auto verification is another thing that's somewhat newer than overrides time-wise. So auto verification has come after with electronic systems that, pharmacies just verifying the med. They're not entering the med as they did in the past when it was paper orders and pharmacy would transcribe those orders. This auto verification, meaning that in that process, pharmacy isn't the one verifying it. But there's different ways institutions may go. Pharmacy may retrospectively verify those. They may periodically, review those. And again, it doesn't have to be someone in the emergency department. This could be someone in admin, a different person, but they look through these overrides just to see, was there an issue? Was there not an issue? So I think that's like the ideal state. If you have this, that it's just not that the meds are on override, but that you have some type of process looking at is it safe or not, reviewing it over time, trying to minimize those as well. And there's some places that really do a great job of this where it's not just in the emergency department. They may look at and they're trying to use auto verification to have medications that aren't as high value for a pharmacist verifying and allow you to spend time doing other activities. So if the patient's not a pediatric, their weight is between a certain, they're not over, say 150 kilos, or they're not under 40 kilos, then it can verify the patient didn't have any alerts pop up on that. It can be a very sophisticated process with that built in. So I don't think auto verification is bad, but verification could be as simple as just pharmacy doesn't see it, or you can have a logic built in there as well. So that's another, especially if there isn't any type of logic or process, it's more likely to be a finding, as well as if the number or the amount of those drugs is very large, it's more likely to be a finding. Um, Other things have seen sometimes is, and this isn't just the emergency department, but could happen because the timing of things are difficult, but the procedures or policies for medications in the ready to use unit dose. So if it's a half tablet or if it's a pediatric patient, are you allowing nurses or someone to draw up the dose at the bedside, or is it prepared by the pharmacy before it's sent up to the bedside? And then again, especially non-emergent medication. So maybe not septic antibiotics or vasopressors, but again, an oral antibiotic for the patient. So that's also a common finding.
Yeah, John, there's been a lot of good chatter happening in the chat, and I don't want to get too far without kind of getting back to one of the things
Yeah.
that Brandon brought up here. And we discussed a little bit about this, RPD time. And a few things that came to my mind was like RPD time. Is that by itself, or does RPC have anything in there? I don't think I see anything in the standard from that perspective. But he mentioned in saying that is that time expected to be per pay period or average over time? Can a program provide a block of time for RPD activities per quarter? So really, is there any language that specifies the unit of time we should be given that, or that we just have some way to measure that? Because I think we all like to have something written out in plain English that we need to get some RPD time. So what's your thoughts on that?
Yeah, it's not necessarily 4 hours per week, but it's on average.
Mhm.
So, if that winds up being that you get, 2 days back to back for the month, that's so it's really average, not that it has to be 4 hours every week. And that's sometimes how someone else from the outside looking in, they might say, well, you have an hour in the morning that you can do this stuff. And again, so that's 7 hours a week, but you may or may not really have that in the emergency department, depending on the flow or the acuity or all of that, especially if you don't have someone to back you up. So it doesn't have to be, it's just that's how they average it. So like 4 hours a week or 16 hours per month on average, but it doesn't have to be specifically that number, or specifically per week. It doesn't have to be.
Yeah, the chat is definitely going fire here, which what we love. And one of the things that came up that now makes sense, I think Brian Gilbert mentioned, do they evaluate, pharmacist administration of drugs, and if nurses get loose lips and then get in trouble, is that something they're looking at?
So they have the standard and and the competencies, goals, and objectives about administration of medications. But if your institution or state does not allow that, then they don't survey you on that. So you won't be, evaluated negatively to say, well, I can't do that. Well, if you can't do that, then you're going to fail that objective. So that's only really if your state or institution allows you to do that. But one of the things that I've recommended for people, because I think it's something really important for us, Not saying to, break your rules or state laws or things like that, but you could still have the residents side by side working with a nurse that this is how you should do it, this is how we do it. Not that you're doing it, but you know how it is, so that if you're then the senior person there and you have a new nurse, you know how you say, "Oh, hang on a minute, I thought it's supposed to be like this." You don't have to touch anybody, but you still understand or were trained how it's supposed to be done. So I still think it's really important, but you may have to, again, look at that differently depending on your hospital institution regulations or state regulations. But if it's not allowed by your institution or not allowed by the state, that would be important to tell the surveyors so that they know, in case they didn't know that, we're not allowed to do this, and then you won't be surveyed negatively for that.
People might want to take a look at their individual states when the governor declares a state of emergency. What is the language on healthcare providers performing duties outside of the normal standard as defined by state law? Because in Illinois, for example, in a state of emergency, any healthcare professional, this is pretty wild, it's the loosest in the country, is allowed to perform any other function, provided that they're the only person there who could theoretically do it under and justify their action. So you could actually, with what John said, you could actually consider, as used to be done in the dark ages, in the feudal ages, in the 1980s, when a certain person on this call was a resident, 84, to be trained by the nurses on how to do venipuncture to draw labs, and how to do art line draws, and how to adjust art line infusions and regular IV infusions on the pump, and we're allowed to do it as part of your practice. But that some of that coverage comes from not just being prepared for everyday practice, but EM being able to do the emergency stuff too under real emergencies. Oh wow, it's all look at the. Can I
So
say
this is
something about surveys, Jimmy, if you don't mind?
go
It's
right
going to be a little
ahead.
bit different. I'm going to be brief because we're chewing up a lot of time here. I think people don't think about the survey strategically. I don't know why. I was exposed to it and I picked it up. But I think RPDs really ought to approach this as not just hell on earth for them, it is, but also as, but I can make it hell on other people too. And if there is something that is really crippling your program, that pharmacy or hospital administration is the major barrier to, then I don't want to suggest that you be an amoral, unethical person who breaks rules whenever they feel like it because their standards are better than the society's, but I would do it. But consider not being completely perfect at everything, because nobody is, and they will find something wrong no matter how perfect you are. I have one other comment on that in a second. Someone remind me. But strategize to make sure that the gaps, put in a deliberate trap for the surveyors to fall into, where they say, well, you can't not be doing this. And then they write it up as this is a major finding. You really need to get this fixed in order to get like ultra perfect accreditation. And the whatever it is now. So they keep lengthening it because they can't do all the programs. What is it, 8 years now? It used to be
8. Mm-hmm.
okay, 5, 6, 8. And they're not all on site anymore either. But give them something, let them have things to find you on. Let them have something you need to have pharmacy admin or hospital admin told. You have to provide this, you have to make sure this happens. And that will make your life easier rather than you say fighting the fight forever about justifying the position. A harder one. But that is one tool I would suggest that you think about doing. And by the way, guys, I just please take a step back and think about this. Where does ASHP publish the list of all the programs that get full accreditation? Where's the gold 8? Where's the star with the 8 points that they give everybody who got 8 years? Where's the star for 4 points because you weren't good enough to get a full? Think about that. You have power they don't let you know you have because they can't afford to lose residency sites. Do they encourage everybody to keep opening more sites for the number of residents? Yes. So it's not a tremendous power. Now, the weakness to some of what I'm saying here is how important is pass through funding if you are an academic institution? How important is that to how many residents there are? And later on, if we have time, I'll talk about the really problematic administrator who wants you to cost justify a resident. And we can talk about that. I have a tip. I don't know if it works for everybody, but it's pretty useful.
But to go with Frank's point of trying to strategize, when you look in those standards, it'll say under each standard, this is a key factor. If this is a key factor, I would if you can't focus on everything, and I agree with what Frank is saying, with accreditation being a test, very few people, if at all, will get 100% on the test. That doesn't mean you won't pass, but you won't get 100. So if you want, what should I focus on? You should focus on those key factors, because those are weighted more heavily, that key factor, if you don't do that. So if I can only do some of the things, look at those key factors and make sure you're doing some of those. For example, your development plan with the new revision of the standards has a lot of key factors on there. So I would make sure you're doing what they recommend for your development plan. And other things, if it's not a key factor, well then, maybe you have to do that next time, or work on it. And it's okay that you don't get 100%. I think that the biggest challenge for a program to not do well is, you have challenges with the program training. And I think that's, even from what I've seen, if they really want to see that you're training the residents well, paperwork is common, but it's still secondary. But if you can't do either of those things, and then they recommend for what you to do, and then they come back and resurvey and you still can't do it, that's a bad sign. So I would look at those key factors, because that's a way to try and, what should I focus on to at least pass the test.
Perfect. Now, I want to keep us kind of moving along in a particular way, because I'm going to skip a few questions and get to some of the preceptor things, because I think that's some things that has come up, and we can kind of bounce back to it. But one of the questions really kind of talked about the types of preceptors. So again, standard for 4 or 5 point B, if as far as like the type of preceptor, so a EM preceptor that completed a PGY2 in critical care, what they consider that adequate, or do they need the additional years to qualify as a PGY2 preceptor? That's kind of interesting when it comes up. Before, we kind of had as many of the PGY2s in EM, but I want to kind of figure out your thoughts on what does a person need for that, and does critical care kind of fit the bill for the type of adequate training? And there was another follow-up question that I received as well.
The standards do talk about this. So if you've completed an EM PGY2, then they want you to have at least 1 year of experience to be a preceptor. But if you haven't completed a PGY2 in emergency medicine, and the way I interpret that is, even if you haven't done a residency at all, because it doesn't really say, but if you haven't done a PGY2 emergency medicine resident, you have to have at least 3 years of experience in emergency medicine before you could be a preceptor. And again, that's also different for an RPD. But so yeah, 4 years wouldn't need be. If they've done critical care, they would need 3 years as experience in the emergency department. And sometimes that may, like, say you had in your PGY2 critical care, you spent so much time in the emergency department or had experience, that could count toward that experience as well.
Yeah, that's a great one, because again, we have a lot of people that's going to be the evident of the ED critical care swing position. I noticed quite a bit of those, and we have some at our shop. And as I was preparing to get all my preceptors in position, one of the things I was like, whoa. For one, does this person count as a current preceptor, even though they work the same shifts as us? And we, in most EDs that I'm aware of that has a few more preceptors, are team taught. Like, do they count towards that, or they have to be a preceptor in training? So that's something that really came up related to this as well. And then the next part of it is figuring out, okay, what's the next steps for that. So I think you kind of hit it on the head. PGY2 and EM or 3 years of training seems to be the two options that we see. An additional question that came up, and it kind of goes on this, like say someone had some things come up where the board mentioned, hey, we need more qualified preceptors, and that term qualified, sufficient complement of qualified preceptors for training, supervision, and guidance, but it doesn't necessarily specify an exact number. And as people are kind of going through it with limited funds to expand, if they recommend that we need more preceptors, but they don't necessarily have enough on that site, could they go to a different, sister hospital to kind of expand the preceptor pool? Can give some guidance on that, because this is one of the questions that came up that would be really helpful for them to understand.
Yeah, I think people could definitely go to another, and people will, programs will do that for things that they don't necessarily have. So, example, toxicology, like we don't have any toxicologists on, staff here, but we could send you in the state or to the neighboring state, so they can serve as a preceptor who then would be qualified, from those, years of experience. And it might not even be emergency medicine, elective rotations. If you have an ICU, that person can be a qualified preceptor as well. But people can definitely go to other program or other institutions, whether that's you might not have peds going to the peds hospital, might not have toxicology, you might be more of a community hospital and you don't have trauma, going to a trauma center for that. I think that's a great way to do that. I think the challenge there is probably more getting um, the legal agreements between the institutions is probably the challenge there. But I think that's a great way to not only get preceptors, but just to make sure you can teach your resident everything with the most qualified preceptors or experiences. And what was the other part of that, Jimmy?
Got I think you kind of hit on it. Basically, them be able to go to different places if they didn't have enough to expand in the actual facility. So say, hey, my managers, I'm not getting more than 2 FTEs for ED pharmacists. Like, and you come back in your next visit and say, hey, you guys still only have 2 ED pharmacists, but they get sent to, the community hospital down the street to have some experiences there. Then they get sent to a pediatric hospital for that, and they have a tox type of rotation. Is that sufficient just to give people more resources?
I think so. And one of the things sometimes the surveyors will try and do that sometimes to try and help, saying you don't have enough, that hopefully it's heard by the leadership or administration that we're saying, as these people surveying you need more people, and try and justify that with saying, like, you have people during the week but you don't have people on the weekend, or you have people during the day but it's not overnight. That's another common kind of pharmacy services thing that I'll see, is as code response. So there's code response, but it's only during the day, but there's not at night. Or there's certain services during the day but not at night. I see somebody's
Well, there
got a
could be
question.
Yeah,
a
sorry.
nearby hospital. Go
I
ahead.
have a quick question I wanted to interrupt on. My name is Carolina. We're from RUHS Medical Center. We're just starting our new EM program this year. We have our first resident. We're in the process of our preceptor development plan and preceptor appointment and putting that document together, reviewing the 2025 ASHP accreditation criteria. There's multiple factors, as you guys mentioned, and I wanted to just clarify something. So one of the critical factors is 4.5B, meaning, like you guys mentioned, the preceptor either must have a PGY2 in that practice area or have years of experience. But I also wanted to highlight that under critical factor 4.6A, that's when the content, knowledge, expertise comes into play. And unless the preceptor has an active BPS certification in that area, they have to demonstrate subject matter by completing, if they haven't completed a PGY2 in the area, down there it says that if they have a PGY, meaning anybody else that hasn't done a PGY2 EM, basically, they have to have at least 4 years of experience, which is, a little bit longer than what it says basically in 4.5B. So that to me means that if they have a PGY2 in another area, they have to have 4 years of experience. Is that correct?
Yeah, I will have to ask. I
And
agree. I think that's what that does, but they do seem like they're
yeah.
um
It's
So
conflicting each
stupid.
other.
our program is taking it as the 4 years just to, follow the direct language that's stated. So I wanted to clarify that. And my second clarification point was going to be in terms of preceptors who then don't meet these critical factors, right? They have to be on a preceptor development plan. And for that, it states the preceptor development plan has to be such that it's fulfilled in 2 years. The criteria are met in 2 years, so then they're preceptors. But for those of us that have preceptors for ICU trained that need 4 years of experience, basically they aren't even eligible for preceptor development or preceptor in training for another 2 years, if I'm making sense.
Right. I mean, I think that the 2 years, as they're saying, that's, the minimum that you would need to achieve that. But if they still need more years of experience, then they still wouldn't be able to be a PGY2 preceptor.
Correct.
Um,
So then I guess when we have those people staffing with our residents, does that, that's not a detriment, then they're just not on our preceptor roster. Is that correct?
Yes, and that's one of the things that I'll recommend when talking. You have people who are non-pharmacists, nurses teaching pharmacists, pharmacy residents, physicians. So someone can still precept, but they're not necessarily listed on your preceptor roster as an official person to evaluate their, competencies, goals, objectives, and things like that. But they can still precept them.
Okay.
There's a lot of precepting that goes on, so they can still work with the residents, they can still precept them and interact with them, but just as you said, they can't be on the roster as an official preceptor to evaluate them for the ASHP goals and objectives. That has to be the person that meets all the criteria.
Perfect. Thank you so much.
Hmm.
And if I'm taking this the right way, just to kind of bring this together, 'cause I knew this would be kind of the location that really, because just the document itself really contradicts itself. But I think in a lot of these team taught rotations where you may have multiple ED preceptors, quote unquote, but say one of the individuals that work 7 on 7 off with hasn't had the 3 years, they're 2 years in. So in my head, I will just take the feedback from them. They can be a contributor to the document, but I would have to, as the preceptor on record or the primary preceptor, be the one who submit that information. So I can take that as, even if it's an ICU rotation that I don't have a quote unquote preceptor for, I can still be able to complete that. I can be part of that rotation to be able to complete it, so to say.
Jimmy, can
Because
I add
again, there
to
may be
that?
enough people.
Jimmy, can I add to that? I think here's another way that you can choose to manipulate the system a little bit. If you have a preceptor who doesn't meet the qualifications, they're very, very good and they provide very good written feedback, specific actionable items in it. Not, oh, you were great, but with specific items. Separating out comments from blank, adding when you have a team thing, you could say, and comments from Jimmy, comments from Manar, about their from in the residence evaluation, you could start building a case. We really want this person to be a formal preceptor. Look how good the feedback is. And you're going to get a team that says, well, under circumstances like this, the institution seems to have a rational approach and thought process. If you can put it into a policy, you'll be okay. And create preceptors by proving their worth. Use what they document and provide to suggest competence versus strictly saying a stupid number of years. The dumbass stupid number of years.
And
Sorry,
the way
I made it to 6:54, Jimmy.
Here it comes.
I did.
So I wanted to ask a few more questions to do like a rapid fire, and people, as you're in the chat, please do. What we're gonna do is we're gonna take all this information that we're having, try to create a document, and of course put it on our website so we're able to kind of feedback from this particular feed, as well as getting all the information that you guys mentioned, and trying to create a little bit more of a reference document for that. More of a general question, and I think I'm gonna do one more before this question here, 'cause I can see this one getting pretty intriguing. Um, as far as from a preceptor perspective, what evidence of preceptor professional development in advanced activities do surveyors look for? I know we have that list there, but is it anything that ranks higher than the other, or what is the thing that does it make a difference in how they are judged, I would say?
And I think for what things they're looking for, especially if you're saying something like an award, is that something external? Is it something within your specialty? Um, Also, is it recent as well too? You want to have something recent, not something you've done 8 years ago. So the timeliness of it. So I think those are important, but some of it is being a clinician part of it, does or being a teacher, but a lot of it I think you want to look at, does it show within your area of practice? So like if you're teaching, you know, kids in high school something, or you spend part as helping teach kids in a school, but it's not any way related to what you're doing versus you're doing that to help teach like BLS, that's more relevant to the person's. So I think it's there's probably a lot of right answers here,
Mhm.
but wrong answers are things that are too old or things that really just don't apply to your practice. So
Perfect.
something that's what I would say are the things that are most relevant.
Perfect. I'm gonna throw another one out there just to hit some people's question that submitted. Uh, Again, with EM pharmacists working 7 on 7 off schedules, what are the best strategies for staffing PGY2 residents on the weekend while ensuring adequate support and in productivity?
Say that again, Jimmy.
So, if with EM pharmacists working 7 on 7 off, what are good strategies for staffing PGY2s on the weekend while making sure they feel supported and there's kind of balancing the preceptors' productivity and support for the residents with staffing?
So I think one thing that helps when they're doing it at different times or evenings, weekends, overnights is to have the resident an escalation before they're in that environment. That they're in an environment maybe on another shift or a shift where there's overlap, that they can gain confidence and have more support before they've gone into that. And usually it's typically at least a month, if not 2 or 3 months before they could be like more independent would be ideal. Um, Not saying they couldn't be independent at all in the other, you can still have 2 or 3 preceptors, but they can go out on their own. But if you're saying, part of the residents here on the weekend and they're alone by themselves for 5 or 6 hours, with no one else in the department, maybe that person in the ICU as a backup person. I think you'd want to have some type of training overlap before the resident, was in that. But at the same time, it might be faster than 3 months if you have someone who's an early commit. And they were here as, it's how you word these things. But the thing you wouldn't want to see is that, oh, the resident staff's on the weekend, they completed the independently every other weekend, and they started this the last weekend of July. That would not be good because for many people that might not be enough, especially if they're new to your program or just not enough in independence, not enough for them to have that level of independence that clear. And then sometimes that seems like, well, is the resident really learning or are they just being used for staffing? So I think, there could be exceptions, but you want to allow that time of overlap with other preceptors, precepting where they can get feedback before they do more independent practice, especially where there's no one around for them except maybe by phone or something.
Perfect. And I would throw two more questions out. I know we're running out on time, so if you guys have to get out, one of the questions that came up that's a really good question, and we're gonna get talking about this. What is the thought or kind of the rationale about publishing resident research? Is there anything that we're looking at? And I saved this for last because I knew this would kind of get people riled up. But is there
Mhm.
anything that, from a survey perspective from ASHP, that they're looking at when it comes to publishing of resident research?
I think that it's more that it's in a format that is able to be published. I mean, and I know Frank will have a lot to say here as well as maybe others, but I think it's good for the residents to get the experience. But at the same point, I don't think if it's not valuable, it shouldn't be published either. Not that, so you want really things of value as well. But when I look at it, it's more that it can be published, not that it is published. So whether or not it is published, that's not a requirement for whether you succeeded or failed with the residency, but it's in a format that you could submit it or you do submit it. But that doesn't mean it's necessarily going to get published. But I think you definitely want to show, does it add value for publication, which that's a whole nother, not resident programs, just anything.
I'm going to add just real quick. I think it important that a resident make an attempt. I've changed my mind over the years, but the resident should make an attempt to publish during the residency year. I did not say their
Mm,
research. I did
mm.
not say their research. The literature that's out there says if they get anything published during their residency year, there's a substantial, whatever that means, a statistically significant, whatever that means, increase of publications or contributions from them for the next 10 or 15 years of their career. It doesn't have to be their research. And I think this focus on the research project has led to a lot of research is research skills are deteriorating, in my opinion, because we're doing too much. Can a resident get it done in 1 year research? And they're seeing that as the pinnacle of research effort. I'll stop there because of time. I could this is a totally separate topic.
And guys, I will leave with one question from Carolina. Carolina, if sorry if I'm saying that wrong. How do you incentivize preceptors to meet our requirements for preceptor development? Are programs including this on their yearly evaluations?
Yes,
I think
I
some
know.
of that is to try and, give them some time, however you can, because that's, I think, one of the things that's hard. I mean, sometimes people can get burnt out, which that's another thing that commonly seen with shift work or emergency medicine, people that have been in it for some time. But, let someone have this administrative time, because that's or this time away from the ED to do those things, even if it's for an hour to review this preceptor development material or something like that. That's really a challenge for different shifts or just for the ED where it's hard to do that. So to use any of that overlap, if you're the program director and you can overlap with them, let them have some time to be able to do those activities. So that's one thing. I mean, for sure, to hopefully get your department to buy into that it's important that we want the folks in the emergency department to do these things, but they're working all these crazy hours. I bring this up many times. They're like, well, why can't they meet at our meeting at 9 a.m. or 10 a.m.? And I said, well, how about you come to work tonight at 4 a.m.? They're like, what? I'm like, what's the difference? So sometimes people just don't understand. But anyway, that's getting off topic.
Yeah. And guys, as this stuff comes in, what I would like for you to do, because I feel like this is going to be we had 7 more questions that we could have answered today, but what I would like for you guys to do, I'm going to put our email in the chat here. Please just email us because I know Frank and John both want to answer more questions. We want to be respectful of time. This can probably go on for a day if we let it. But that's one thing I want you guys to do. So if these things come up, we can take this as a question here, or for you guys that are members, go on our discussion board. We have a place for RPDs, and we have some things we want to put there. So I would definitely encourage you guys to ask more questions, get more information. And the best way to do it, I know some people may feel a little worried about not being anonymous because again, John may be their preceptor. John does a lot of precepting. So what you can do is you can find a way to put it in there. You can email us and then we can kind of get it sent to John, de-identified, so we can get back and forth to you guys because this is a very important topic. Um, Last few things that I will actually mention is as we get set up, guys, we talked a lot about research and we can actually lift this by telling you guys again, you can publish your papers. I know that residency projects recently got completed. This time for manuscripts. Definitely go visit our website. Again, we have everything ready and open for submissions for JCP. We're open access journal and we have no APC at the moment. We get our first edition through. We have a ton of articles in the pipeline now, and we really would like for you guys to be able to publish in our journal. One of the things I want to mention that we were able to provide is that there's a lot of different types of papers that we can take in. So the original research, review articles, case reports, practice guidelines, those are part of it. But we also are going to be having this special type of just short educational content. So a lot of you individuals are doing whiteboards and you guys are doing different small short form education to your team. We're going to be opening that up at some point as well. And if you guys have any questions, you can definitely reach out to us. And Brian Gilbert, who's on right now, is our editor in chief, so he can be able to answer a lot of those questions. And we really look forward to being able to provide a different platform for all acute care pharmacists. So again, JCP is going to be for all acute care. So
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.